I'm Dr. Rick Greene, and it is my pleasure today to be the host of a video interview celebrating the 100th anniversary of the Commission on Cancer. And during this celebration, we're highlighting the past cancer department directors. And it's my privilege today and great honor to be interviewing Dr. Monica Morrow, who is a friend and colleague for a long time. So Monica, welcome.
Thank you very much, Rick. It's a pleasure to be here.
So rather than just start with your work as the director of the cancer department, you were a member of the Commission on Cancer well before that. And I just want to ask you, how did you become involved in the commission? And once involved, what were your interests in the Commission on Cancer?
Well, I had done a surgical oncology fellowship at Memorial Sloan Kettering, and I took my first academic appointment at Kings County Downstate Medical Center. And needless to say, there was a rather dramatic difference in being at a tertiary care cancer center like Memorial and then moving on to a city hospital like Kings County. And there were a number of opportunities, I think, for improvement and standardization of care. And I think I actually got asked at that point in time, as the young new faculty member who was getting appointed to do all jobs that required work that no one else wanted to do. I think that is actually how I became involved initially with the Commission on Cancer. Having said that, it turned out to be an incredibly rewarding thing. And that's why after I moved on from downstate Kings County, first to the University of Chicago and then to Northwestern, I stayed involved with the commission because I thought they were doing really important things to try and set up some standards for cancer care in this country that were greatly needed.
So, right, that takes us to Northwestern. You were a busy clinician. You were head of the Lynn-Sage breast program there, obviously extremely busy. And so somebody came to you one day and said, how about becoming the cancer director or the department chair of our cancer department? And how did that work? I mean, as being a busy clinician, having administrative roles, teaching residents, teaching fellows, how did it work having another job?
Well, I think that was an illustration of be careful what you ask for, because sometimes you get it. So I was looking for a new challenge. I was very happy the Lynn-Sage breast program was thriving, and I enjoyed then and still do enjoy my clinical practice, but I was looking for a new challenge. I had been involved with the commission and had headed up committees. And so when I got asked to take that opportunity, I was also considering a role as chief of surgical oncology. And I talked to David Narwald, who was my chairman at the time, who suggested that, the Commission on Cancer had the opportunity to have perhaps a bigger impact on cancer care in the country than simply leading a program at a single institution, which when I thought about it, I agreed with. And that was very appealing. And that was also a time when the commission was moving from what it was when I started, which was very, very, very focused on process. You had to have X number of meetings a year or you got dinged of your cancer committee or your tumor board. And it didn't matter if your tumor board met on Monday and Monday was a holiday. If you didn't have enough meetings, you were in trouble. Now, obviously that is a little bit silly. And over time, we moved much more towards looking at real outcomes as opposed to process. And that transition was happening during the time I got invited to take the role in leadership. And so that was also an attractive thing. So it was a combination of factors. How was it? My life was crazy then.
So you were cancer department director from 1999 to 2000. But in that period of time, you had such an influence, and I know because I was around then working with the commission. And first of all, in ACOSOG, the American College of Oncology Clinical Trials Group, I mean, obviously you had an interest in trials and breast cancer and other things. Tell me about ACOSOG and what was the importance of bringing that into the commission?
Well, ACOSOG was a real revolution for surgeons and surgical thought, I think. Not that there hadn't been surgical cooperative groups, because of course the NSABP was founded by Dr. Bernie Fisher, who was a surgeon and had been conducting surgical trials that changed the landscape of breast cancer and later colon cancer for many years. But I think the idea that the college would give its imprint to a clinical trials group represented a shift in surgical thinking, and one that was not necessarily widely welcomed by some other members of the cancer community. I can remember hearing some well-known medical oncologists saying, they're going to be giving money to surgeons that, they're taking away from us. How could this possibly be? But I think it recognizes the importance of surgery in the cure of solid tumors, which it remains the mainstay of treatment for solid tumors, even in today's modern multidisciplinary treatment world. And so I think bringing this into the college, bringing this into the commission was recognition of the importance of that for all surgeons.
And of course, you mentioned your interest already in standards and standard setting. I think a great contribution was your involvement in the National Cancer Policy Board. I wonder if you talk for a minute about what that involvement was. What was that board all about? And what was your role in bringing commission activities to that board?
Well, the National Cancer Policy Board was a part at that time of the Institute of Medicine, the National Academy of Medicine. And like most cancer activities at the national level, was dominated by the voices of medical oncologists. And if I recall correctly, I'm pretty sure I was the only surgeon on that board during the time I served. And I believe I may have actually been the first surgeon to serve on that board. And they looked at things that, should be standards. They wrote important policy statements about what constituted quality care and what should constitute quality data and things of that nature. And I think it's just important when you're making those kind of statements that are widely listened to and have the potential impact to garner funding and affect policy at a higher level, that you need to have the voice of all stakeholders. And the voice of surgeons, had not been heard. And surgical needs are a little bit different than the needs of medical oncologists, radiation oncologists. So it was a rewarding experience for me, and one that was certainly illuminating in understanding how other people thought and how it might differ from the way we did things.
Well, I think you opened up a whole lineage of bringing commission activities to advocacy and other things that were going on, certainly in the Beltway and around. You also were the leader 10 years after the NCDB. The NCDB had come in 1988, 1989, as you know. Tell us a little about your thoughts about what the NCDB brought to cancer care and the value of the NCDB.
Well, the NCB is just a tremendous resource, and its importance as a resource has only grown over time because, now it is a sampling, albeit not a classic population-based registry in the way that SEER is a population-based registry, but it samples, I think, 85% of incident cancer cases in the United States or something like that, and provides treatment data at a more granular level than what is available in some of the population-based or registries that are based, for example, on Medicare populations and that sort of thing. So it allowed us to start asking surgical questions outside of single institution studies and get a much greater landscape of what was going on across the country in cancer care and the variations that we saw. And I think one of the things that I focused on during my time at the commission was to try and improve the quality of that registry by hiring data people who were professional, full-time, experienced data people to deal with that, and beginning to set a more rigorous way for how do you get access to the data than simply being a friend of somebody who was on the commission. So I am happy that I started that along the way. It's certainly grown a whole lot more since then and puts out lots of important clinical research.
Finally, I want to ask you, you've been involved in National Cancer Institute core comprehensive cancer centers throughout your academic career. Tell me a little, what is the value of an NCI core comprehensive cancer program being involved in commission activities? What does it bring to the commission?
Well, I think that certainly having NCI designated cancer centers as a part of the commission, in a sense, gives a stamp of approval to the commission saying that we value your activities. We think that they're important enough to invest the time and resources, even though perhaps for a major cancer center, saying that we are a Commission on Cancer approved program is not necessarily the same thing as for a smaller hospital in the community where it attests to the meeting of a certain level of standards. But I think, in fact, you know, there are so many things in cancer to look at, and the NCI grant funding process looks at one piece of cancer care, which is very heavily focused on generation of new knowledge and outreach into the community. And the Commission on Cancer looks at a different thing, which is what's the quality of care you're delivering. So I think they have a very symbiotic relationship, and it's mutually beneficial for everybody to participate in both.
Well, Monica, I want to thank you not only for your leadership as cancer director of the department in Chicago, but also for the years that you've devoted to the Commission on Cancer. And as we celebrate this 100th anniversary, I can't think of a better person to bring into this discussion. So I want to thank you so much for what you've done.
Oh, thank you. And I would simply say I got far more from the commission than it gave to me. So I'm happy to have participated.